Good afternoon, dear chairman, dear audience. In the next few minutes, I would like to present my current progress of my PhD work entitled Investigation of the Effects of Biological Therapies on the Cardiovascular Risk. I'm Noémi, Galajda, PhD student at the Department of Dermatology, Venerology and Dermatooncology of Semmelweis University. I'm doing my work under the supervision of Ágnes and Péter Holló. During my research work, my vision is to reduce the burden and mortality caused by comorbidities associated with immune-mediated inflammatory diseases. And in order to achieve that, I would like to optimize the therapeutic sequence or order, taking into consideration their effects on the comorbidities. I have two ongoing projects. Both of them connected to a group of biological therapies, TNF-inhibitors. In the first project, we investigated the effect of TNF inhibitors on the risk of different kinds of cardiovascular events in all immune-mediated inflammatory diseases. Cardiovascular diseases are among the leading causes of morbidity and mortality worldwide, and the major pathogenetical background for this atherosclerosis, in which a key inflammatory player is the tumor necrosis factor. This cytokine is also plays a pivotal role in immune-mediated inflammatory disease, emits pathomechanical background. And among this population, there is an increased risk of cardiovascular events compared to the general population. Biological treatments inhibiting this cytokine, the TNF inhibitors, are widely used biological treatment options, and through the inhibition of these immunological pathways, they may have a beneficial effect on cardiovascular comorbidities. Unfortunately, because of their high cost in most regions of the world, they are not among the first-line therapies. Whereas the conventional immunosuppressants like methotrexate and cyclosporine, they are much more affordable. However, they do not directly act on TNF-mediated pathways. Based on this background, our aim was to investigate the effect of the TNF inhibitors compared to the conventionally used therapies on the risk of cardiovascular events. Our clinical question was whether TNF inhibitors have an effect on the occurrence of cardiovascular events. We included all immune-mediated inflammatory disease patients who were treated by TNF inhibitors, and we compared non-TNF inhibitor-treated, non-biological therapies-treated patients, and our outcome was the incidence of cardiovascular events. We hypothesized that TNF inhibitors can decrease the risk of CV events compared to the non-biological ones in IMIDs. So we conducted our systematic search in November. We got more than 8,000 hits, and after this selection process, we got 56 eligible articles, from which 29 could be included in the meta-analysis part of our work. From this analysis, I would like to present now our major outcomes with incidence rate ratios with 95% confidence intervals. First, I would like to present the major adverse cardiovascular events among associated psoriatic arthritis, rheumatoid arthritis, and also inflammatory bowel diseases patients. We compared the TNF inhibitor-treated patients with the conventional systemic non-biological treatment, CSNB group, and our measure of effect was incidence rate ratio. You can see that our overall effect here was 0.77, which means that TNF inhibitors can decrease the risk of MACE compared to the CSNB. And this beneficial effect could be observed in subgroup analysis as well. This result was not only statistically significant, but also clinically relevant. Our next major outcome is the cerebrovascular events. We investigated the same population with the same comparison groups And we got the very similar overall effect, 0.69, which means that TNF inhibitors can decrease the risk of cerebrovascular events with about 30% compared to the CSMB group. And although in the subgroup analysis the results were not statistically significant, the beneficial effect of TNF inhibitors can be seen as well. And last, myocardial infarction risk among the same population with the same comparison groups, and we got the very similar overall effect, which result was also statistically significant, and we can say that it is highly relevant clinically as well. So we have some strengths and limitations. Our major strengths is this is the first comprehensive review including autoimmune-mediated inflammatory diseases treated by TNF inhibitors, and our analysis was the first result that confirms the benefit the TNF inhibitors versus the conventionally systematic CSMB treatment. But this is one of the limitations is that these were observational, prospective, retrospective, observational trial studies, and the heterogeneity of the outcome definitions and the comparator groups were high. So we can conclude based on our analysis that TNF inhibitors can decrease the risk of cardiovascular events in comparison with a conventional agent. And our implication for practice would be that first line or earlier use of TNF inhibitors over the conventionally systematic non-biological treatments could be recommended for individuals with a higher risk of cardiovascular events. And our implication for research is that randomized control trials, use of unified cardiovascular event definitions, standardized follow-up times, and also the direct separate comparisons of active substances are necessary and needed. We submitted our manuscript on 27th of July, and it was under review for a month. And 2 days ago we got feedback, it was rejected by the European Heart Journal, which was our first target journal. And now, after revision and correction, we would like to submit to the autoimmunity reviews, which is our second target journal. In the second topic, in the second project, we would like to investigate the same biological treatment group regarding on the risk of heart failure. As it was mentioned, TNF inhibitors are widely used and generally safe, well-tolerated biological treatments. However, multiple potential adverse effects have been associated to these biological treatment groups, and one of them is the heart failure. The Food and Drug Administration in 2003 reported a case series with 47 cases with a new onset and worsening of heart failure, and since then the therapeutic guidelines are recommending the absolute contraindication of use of TNF inhibitors in several cases of heart failure and the cautious use in milder cases. However, the clinical results of the clinical trials, cohort studies, these studies' conclusions are very controversial, and based on that, we would like to systematically review this topic and investigate the effect of TNF inhibitors on the risk of heart failure as well. So our population would be the same, and we would like to compare TNF inhibitors, placebo, and non-biological therapies. and the outcome is the occurrence of heart failure, and we would like to make subgroup analysis based on de novo and exacerbation of heart failure. And our hypothesis is that TNF inhibitors do not increase the risk of occurrence or the worsening of heart failure in IMIDs. Our clinical implication would be, in the light of our results, that revision of therapeutic guidelines for the use of TNF inhibitors could be considered in persons with heart failure. So we conducted the systematic searching for databases. We used this simple search key, and we got more than 6,000 articles. After the duplicate removal and the title and the abstract selection, we got 116 articles for the full text selection. So currently we are here with the second project. I would like to thank my supervisor, the great help during the whole year, and now I would like to thank you for your attention.
Thank you for your presentation. In your first topic, you show us a visualization of the plots, and next to that there is a risk of bias assessment visualization. And my eyes are not so well, but I think the result is full red everywhere, so it means it's a high risk of bias.
Yes.
Then why is that your conclusion? What's the reason of that?
Yeah, thank you for your question. I was very critical. First of all, it's because these were not randomized control trials, and there are several weaknesses in these studies regarding the comparison groups, the composition of these comparison groups, that we couldn't do a direct comparison of the active substances, dosages, and so on. So these were basically mixed groups, and with heterogeneous outcome. But the short answer is that these are not randomized longitudinal, prospective, and several retrospective studies as well. So this is the answer.
Okay, thank you.
Following this line, I mean, you have already received reviews, right?
Yes.
From the European Heart Journal.
Yes.
And has any of the reviewers picked on the very high risk of bias? And my question is, how will you handle that? What would be your response? How would you defend the strength of your paper based on such a high risk of bias? Because you have to do that, otherwise the reviewers will not accept your conclusions. And it's not good enough just saying that these are not randomized trials, because then you have to really tone down your conclusion. So, I mean, how will you find a balance in that? Do you have any plans?
Yes, thank you for your question. The reviewers haven't criticized the fact that these are high risk of bias studies. They made suggestions regarding the using the right tool, because I used Robin's eye for all of the studies, and they recommended other tools as well, but they didn't criticize that these were high risk of bias studies. We can balance with this. We can suggest for the researchers, future researchers, to do randomized control trials and make better studies. So with these current studies, we couldn't make any difference. I don't know if it was a question or...
No, I just want to help, because if this is the case,
yes,
then you can strengthen your paper by writing a very concise and robust implications for research part. by criticizing almost each and every trial, pointing out the limitations of these studies, and then, because then this would have been possibly the strongest message of your work.
Yes, thank you. I mentioned and I highlighted in the limitations part, but maybe I will highlight more. So this is an important part, yes.
So we're almost out of time, but still as a quick question, if you don't mind, in your second project you said that the implication from your study is that you may have a prediction whether TNF inhibitors could be safe for heart failure patients, right?
Yes, or at least the revision, or because since the early 2000s, there is no
no consensus.
Yes, again.
But maybe just I suggest with caution, because basically none of your patient populations have HF. So I think it's really difficult to translate whatever you find in a healthy population. So I think you may want to work on that a bit. Yes. But congratulations.
Thank you.